With this little introduction, I'd like to invite our first keynote speaker to the stage. His name has already come up here a few times in the little 10 minutes or half an hour that we're here. Not a professor yet. Dr. Tomáš Páleníček from the National Institute of Mental Health. He is a psychiatrist and a neuroscience researcher at the 3rd Faculty of Medicine. He is the head of the Psychedelic Research Center at the National Institute of Mental Health, where both clinical and preclinical research takes place. And he's also the founder of Scion, along with colleagues. They mentioned the psychedelic-assisted therapy clinic, the first one in Czech Republic. And with that, I think I will give you the stage. Enjoy the talks.
Okay, thank you very much for inviting me, and thank you for organizing this event in Prague. It's quite busy days because we have another workshop in 2 days, and we had a movie premiere that you will see today during the day as well. So it's quite a lot of things ongoing over the last few months. So it's my pleasure to be here, and I was asked to go a little to share a little bit of the overview what we did here in Czech Republic, or how it looks like. So it's kind of a taste of what we are doing here, and I will not bring up too much results. There are others that will speak about what we are doing, about our clinical trials, or about the experiments in healthy volunteers that they did in here, or traveling even to far places like Canada. So here are my conflicts of interest. As was mentioned already, I'm the co-founder of Scion Clinic, and I'm also the co-founder of Cyrus Foundation. And we recently have a company also that hopefully will be able to make some GMP products that might be used in psychedelic research. So it was already mentioned that Czech Republic has a long history of psychedelic research, and I just make a little bit dive into what happened in the past. And there are names that many people don't know, but in 50s and 60s, there's quite a lot of psychedelic research ongoing here. And there were pioneers like Dr. Wojciechowski, Robíček, and the others who did quite a lot of stuff in patients, and they published books which are unfortunately in Czech, but with today's tools, some of the chapters can be found online and can be translated. And there's lots of work done also in the pharmacology. I was recently writing a paper together with colleagues it's running automatically. With colleagues from Groningen about psychedelics, how they can be used as an adjunct to standard pharmacotherapy, and actually one of the oldest data on combinations of psychedelics with psilocybin or LSD are coming from these old studies, from these pioneer studies from Czech Republic, like psilocybin and monoamine oxidase inhibitors, and LSD with monoamine oxidase inhibitors, and so on. And it was done by these people. So this is one of the early experiments that was done already in patients. This is with OCD patients. So already at that time in 60s, we had some information coming from our country that psychedelics can be used in a therapeutic context. There's one name quite famous, which is Dr. Hausner, who worked in Satzka Hospital, who did who treated a lot of patients with psychedelic substances. And there's one Canadian journalist who was really diving into what happened in Satzka, and he published some nice stories about it, and with pictures and everything, which is Ross Crockford. So you can also find it online. There's lots of being done in the therapeutic field here. There were also militaries were interested in psychedelics, and there's a famous experiment that is also on YouTube as a video of military troops that were given LSD, and they were asked to do some training, and actually it completely failed. It's really a funny video, so you can also find it on YouTube. There's one paper published by our recent director, Peter Winkler, that's also describing the self-experimentation with psychedelics that happened in these pioneer times, because obviously the old psychiatrists, they did experiment with these substances, so you can find a lot about it. And already mentioned Stan Grof. This is a picture from the EEG lab that was in Prague Psychiatric Center, which is the institution where we started our research before we transformed into National Institute of Mental Health as our team some time ago, together with Stan. And there are also other people which are not so much known, but they're very well known in the therapeutic community, like Juraj Štik, who is actually Slovak, but he emigrated to Basel. He's living in Basel. He's one of the therapists that is approved for psychedelic and psycholytic therapy with substances in Switzerland. And this is a recent picture from last summer with him here in Czech Republic. So he's still in a good faith and a good health. So how it happened? In 50s and 60s, there was lots of research, but then obviously, like everywhere, everything was blocked. And I show a little bit my path. How do I get to psychedelics and psychedelic research? When I was a student, I was obviously interested in this drug, as many people are. And actually, I reached at that time an assistant, Magda Fischerová, now Šustkova, and we discussed on the pharmacology department whether we can publish something. And we published the first review paper about MDMA. And at that time, I was also working in drug services, and we went also to Austria to meet CheckIt and went for their Love Parade, and they're making all the drug testing on parties and so on. So we started to do something like that and published the results, and there was a database at the time with ecstasy tablets and their and the content of the substances in there. So that was something while I was already studying medicine. And then, it was kind of a coincidence, I met Professor Jiří Horáček, at the time assistant Jiří Horáček, was quite young, and he offered me whether I don't want to do a PhD at so-called Prague Psychiatric Center. So that was in the old hospital of Bohnice, big psychiatric hospital, and it was the Research Psychiatric Institute before, where Stan Grof worked, and many others. And I said, okay, and what are we going to do? Well, I will study models of psychosis, the role of serotonergic and dopaminergic model of psychosis, because he told me, okay, you're interested in psychedelics, but this is very close. We use ketamine, and you might use other drugs to model psychosis. I said, okay, why not? As I said, last week, or this week, our former director, in fact, the founder of National Institute of Mental Health, Professor Cyril Hescher, passed away. There's a funeral tomorrow, so that's quite a sad moment. And without him, anything that we did here wouldn't be possible. He's actually the official tutor of my PhD thesis, while the tutor specialist was Professor Jiří Horáček at the time. So this is what unfortunately happened in the last week. Anyway, if you move on, there is the first research was happening at the Prague Psychiatric Center, and this is just an example of projects that we got. And my PhD program, even though I was focusing on, or my topic was serotonergic and dopaminergic models of psychosis, I was interested in, obviously, psychedelic substances, so I wrote a first grant, and actually it got funded. And at that time, it was quite easy to get funded, even for PhD students. There were no requirements for age index or something like that. So in 2003, we got the first psychedelic research project, and we need to get the substances and the permissions to work with and so on. And then we continued, and obviously all of that was, most of these studies were in animals. The first project in humans was in healthy volunteers, and it wasn't a clinical trial. It was an observational study which was with ketamine and led by Jiří Horáček, the one in yellow, where we evaluated the effects of ketamine using fMRI and EEG, and some of the data were already published. So these are some of the papers coming from these pastimes. We did studies on sex differences, MDMA, LSD, and lots of stuff with 2CB and mescaline and so on. Then, after the first trial was done, we had an experiment with it wasn't an experiment. We knew that ketamine was already shown to be effective in depressed patients, and we treated our first patient with ketamine. It was an IV infusion, 30-minute infusion. It was a severely depressed patient, pharmacoresistant. He had a nervous vagal nerve stimulator, so he was really pharmacoresistant. And he got this infusion. It was like click, and the day after, he was just without any depression. He was a painter, so he started to paint, and the effect lasted for a week, and then it went down. So we tried to do a repeated dose, and it didn't work. We tried to do ECT with ketamine. It also didn't work. But that was the first patient, and since then, colleagues at the Prague Psychiatric Center who were kind of skeptical regarding psychedelic drugs said, okay, let's do something. And Jiří was the first one who got the project. No, actually it was Peter Schoss, but under supervision of Jiří, who got the first project in depressed patients. There was already a clinical trial and starting to study the effects of ketamine in patient population. Over the time, it came to several other projects, and there's quite a lot of data being collected, and some of them are still in the process of publication. This is the first study of ketamine in depression that was done at still Prague Psychiatric Center, and you can see the rapid decrease of depressive symptoms following ketamine, and that it persisted for approximately 7 days. It was also one of the first studies that correlated the psychoactive effects with the antidepressant effect, and showed that the intensity of psychoactive effects seemed to be predictive for the antidepressant response. So that was quite a while in the past. This is a nice study. We were asked by anesthesiologists that, you're doing such nice things with ketamine, and we work with ketamine, and we want to use it as an drug that would enable to work with intellectually disabled patients, which are unable to get served during the dentistry or other approaches. So they were actually giving a mixture of ketamine and clonidine, or ketamine alone with midazolam, to these patients, and they went to the dentists in order to make the dentistry there. And for me it was a very interesting experiment because I was observing all these videos from there, and actually that was the first oral administration of ketamine, and we are now using it quite frequently in our patients because we use the different forms. We skip from IV to IM or oral, and it works pretty nice, even though there's high variability in the plasma levels following oral ketamine. So anyway, that was a very nice study. I liked it, and like a proof of concept that we can use ketamine orally and quite safely. The first psilocybin study was the one I got in the approval in 2012, or actually the approval was later, but the first submission was 2012 for the protocol, and that was in healthy volunteers. At that time, it wasn't possible in Czech Republic to perform studies like observational studies. Everything, and it's valid until now, anything we do, we administer to people, it's clinical trial. So actually, despite people in England were able to do observational studies, we were forced to do a clinical trial. And those who are aware what clinical trial means, or those who were aware and are getting aware what clinical trial means today, they can understand how much work is it to get it work. And this is actually the first publication from this project. We just finished it last year, or terminated, but the last patient was enrolled, I think, in 2019 or something. We were still expecting to get new psilocybin and to extend some of the studies. So it's quite a large project, but collecting lots of data, and some of them are already published, and I will show some of them. And then we moved to a patient population, and these are two recent projects that we are currently working on at National Institute of Mental Health. They're already in depressed patients and in patients with diagnosis of a cancer. And we're trying to compare the effects of psilocybin to ketamine. Vivian will speak later about one of these projects, how it looks like in depressed patients. And the primary outcome is just to see whether psilocybin has the same potency as fast-acting antidepressant as ketamine. And the secondary objective, or one of the key secondary objectives, is how long the effect will last. And our hypothesis is that psilocybin should last longer than ketamine, based on the data that are already available. And the most recent project we got funded, we became part of the consortium with PsyPal, of the PsyPal consortium, which is a project funded from European Union into the palliative care. But in this case, these are not oncological patients, but these are patients with different disorders, which is multiple sclerosis, amyotrophic lateral sclerosis, chronic obstructive pulmonary disease, and atypical Parkinsonism. Quite challenging project. The protocol is approved. We should have site initiation in May in Czech Republic. Groningen and is the primary site with Robert Chavez, who is the PI, and the other sites are in Denmark, in Copenhagen, and with Jan Stenbeck, and in Jean Palimont Foundation in Lisbon with the clinical team who is focusing on the atypical Parkinsonism. These are the sites that are involved in this project. It's not only the clinical sites, but there are many other institutions also involved, taking care about the patient support and networking and so on. And as was already mentioned, we founded a Scion Clinic a couple of years ago. It's a clinic that should enable access to psychedelic treatment, at the moment ketamine treatment. So in fact, it's a I would say it's the first European ketamine clinic, because we were really the first one who started. But let's say there were more clinics starting around the same time. And we are also hoping to bring in other substances in near future. Currently, we are also undergoing, or we are part of the clinical trials that are happening around the world, like Compass and MindMed with LSD. We did the GH research study together with them, and so on. So this is a little bit of the of what happened from the past till now. I'll show you one thing. This is actually our first experimental dosing room. This is an EEG lab that we have in National Institute of Mental Health. I don't know if anyone was in the Faraday cage, normally white walls and nothing around. So we designed it in this way. And we already had some interesting people there some time ago, which I'm proud of. And this is our recent dosing room for patient studies, which we have at National Institute of Mental Health. And this is another one that we have in Scion Clinic. We try to fulfill the guidelines for psychedelic-assisted therapy. So what's happening now? What we are doing now? We have, as Isis mentioned, our team is quite broad. We are covering large area from preclinical up to clinical research. And actually, one of the most funny project to me, I like Czech people. They like mushrooms. They go and pick up mushrooms in the forest. And actually, I was contacted by Eyal from Israel, but I don't want to collaborate on a project. And we submitted a project proposal, and we got funded it. And it's a very nice project that should explore the content, the composition of the content of the liquid mycelia grown under lab conditions, and focus on neuroplasticity. So we got this project. We're working on it, and this is from a review paper that is published, pictures from that, and our team is focusing on neuroplasticity, and his team is focusing on making sustainable production of a liquid mycelia, which is very, very interesting. One of the things that we are doing is focusing on neuroplasticity. You've probably heard that psychedelics and the antidepressant effects of psychedelics are related to neuroplastic effect on the synaptic level mainly, and we are studying the processes which are related to this. So these are data that are already accepted for publication, showing that psychedelics, namely psilocybin and ketamine, induced synaptic plasticity, like many others showed. And we currently advance, and we have a collaboration with University of Erlangen, where we did some RNA sequencing, and we wanted to find find out like common pathways which are shared between dissociatives and psilocybin. These are unpublished data, so just a quick jump of that they identified hundreds of genes, and actually they found two common pathways for two substances with upregulated and downregulated genes. And if you look where it happened, it really looks like that's in the synaptic area and also in the glial cell that support the maturation of synapses, and in the synaptic organization and so on. There was one gene that was surprisingly identified, which we found that was decreased by both drugs, which is the LINGO-1 gene. And there's a very interesting gene that was never explored before, and we are going more deeply into it now. It's a gene that suppresses the branching and prolongation of the axons and suppresses myelination. And the antibody against this gene, for example, has been used to treat clinically or tried to in clinical trials to treat multiple sclerosis and other demyelinization disorders. And actually, it seems that both drugs, ketamine and psilocybin, inhibits this drug, so it could de-block the inhibition of synaptic plasticity. So it could be very interesting common mechanism, and we are looking into it. So these are like very recent stuff. One of our students is doing a very interesting research, which is focusing on whether animals do hallucinate or not. And what do you think? There's lots of animal research in rats, but do we know that rats hallucinate or not? What do you think? And how would you prove that? That was quite a challenging experiment. It's also currently accepted for publication. He compared the human model and the animal model. He actually made it viable that he found out that in this Y maze, he proved that animals are unable to distinguish between images that are changing their shape and those that are static. And he also advanced and made another experiment with electrophysiology, proving that the motion onset in the visual perception is affected by psychedelic drugs. So that we have the first proof that psychedelics do induce visual perceptual changes in animals, because we cannot ask them. So that's a very nice stuff. We do a lot of on animal studies with EEG, neuroimaging. Some of the data are published. We already moved towards source reconstruction and validation of models, and we are now able to compute high density connectivity within brains. We are doing clustering based on the EEG and multimodal imaging of drug effects. We are continuing with behavioral pharmacology studies. We are also doing lots of novel psychoactive substances research with all these novel drugs that appear on the market, and we are also doing the clinical trials. So this is the healthy volunteer study that we just recently finished, and that's the design of our trial. It was quite a long trial. We were collecting quite a lot of data. Some of them were related to EEG, some of them were related to fMRI. And the thing is that with this study, we were able to give psilocybin twice to subjects, and we were able to evaluate the long-lasting effects, because the legal authority required this long period between dosings and to show some safety issues. So we collected the data on persisting effects questionnaire, and we were able to evaluate the long-lasting effects as well. So some of the papers have been published from this study, so you can go through these papers. Because the time is jumping, I will just skip these slides from the results and go to the last thing, which you will probably see in the movie. And we are also doing field studies, and this is something we were always interested in. The field studies are of very huge importance, because it gives us the information on how the substances work in the natural environment, and also we can get the information from the traditional context, how they were used, because you are aware that all these substances have been used by natives in especially in Central and South America. So we did the expedition to the Amazon. We wanted to study the effects of ayahuasca and the group context during the ceremony in the Amazon, and we wanted to look on how it affects the brain. And one of the hypotheses was whether the ayahuasca ceremony would increase the interbrain synchrony, which is related to the dynamics of the group processes. So just a little bit of the taste, how we arrived, how it looks like there in the Amazon. That's where the science can bring us. This is Maestro Juan Flores from Mayantuyacu. That's the Maloca there. And you will see in the movie as well. This is our team ready for hyperscanning, recording, now ready for the ceremony. Let's have a look what we found out with hyperscanning. Do you know, what would be your estimation? Does ayahuasca increase brain synchrony in between subjects, so-called interbrain synchrony, or decrease during the ceremony? Okay, that's expected then, but no one proved it yet. So actually we did quite a lot of analysis before and pre-processing and so on. And these maps show all subjects together in one map. So it's a measure of connectivity within the whole group of people there. And what we actually see is that the red color means increase, that there is an increase in connectivity at around 1 hour. And we had 2 ceremonies there. So the first line is the first ceremony where we were drinking 1 cup. And the second ceremony, we were able to drink 2 cups. So there's kind of a biphasic effect. So there's an increase, then we sit down, drink another cup, and then we dive back again. And there's again a second increase of the connectivity within the group. When we look on the spatial arrangement, there's lots of things that play around. So now you see the heads arranged in the space, how we were sitting in the Maloca, and you can see that the interbrain synchrony, which is represented by the connecting lines, is increasing following ayahuasca. We also evaluate something which we call modularity index, which you see on the right side. The bigger modularity index means the people are more segregated. The lower modularity index means there's less difference between people. You can imagine it in this way. So high modularity index, people are within themselves. Low modularity index, they're connected more with the others. And actually we found also this parameter to be decreased by the ayahuasca, and you can see the biphasic effect with the second ceremony. So because the time is short, it was just like an overview what we are doing. We're doing lots of hard things, we're doing lots of crazy things, and we're happy to have lots of talented people here like Isis and Vivian and Marek and many other students who are coming for collaboration from Vilnius and from other places. So that was just an overview. And anyone who wants to see and visit us, let's get in touch, and you're welcome to visit the labs and the team and share some time with us if possible with our capacities. And one of those who are the main sticking guys are Marek and Isis, who are making the first contacts with most of the people around. So thank you for your attention.
Thank you, Tomáš, for a really fascinating talk. We have some time to take questions. By raise of hand, please, and we'll bring you the microphone. While people are thinking, maybe I'll ask the... Yeah.
Hello. Thanks, that was really interesting. Could you maybe just at a very high level just give a quick summary of the differences between the administration of ketamine, IM versus IV versus oral? If there was anything interesting there.
Yeah, the IV is very fast, and it's with a pump, and it lasts. There's a continuous pump that we usually use a bolus dose and then maintenance dose for 30 minutes. So the onset is very quick, and then when you turn off the pump, then it disappears quite quickly. The experience is usually quite profound, and it's quite predictable how intense it will be. I don't have so much experiences, me personally, with IM, but we do it a lot in Sion, and it's quite also nice to predict the effects. And it's nice to titrate the dose as well, and the duration is pretty much stable, and usually within 2 hours people are getting back to normal. We also use subcutaneous administration, which is pretty much comparable to that. Me personally, I like the oral, even though there's high variability in the absorption. But there's this, let's say, longer time of the onset, so people can taste and work with losing the barriers and getting into the experience. It's very nice to titrate, and the duration is about 2 to 3 hours as well. It's quite fast. The onset is also quite fast. It's within usually 20 to 30 minutes. They're peaking. They're already in there. So, but there is this high variability, and each subject is absorbing differently. Of course, we take care of what so they are on an empty stomach, and so there is not the risk of vomiting, and if there is, so they do not vomit too much, and so on. We can pre-medicate subjects. Usually, one of the most frequent side effects of oral administration was vomiting, which is less with intramuscular, for example, and I saw it only once with IV, but it can be pre-treated by ondansetron, for example, and that's effective. That effectively blocks. And the second major effect is the headache, but this could be also. So usually the headache could be a result of increased blood pressure in some, but in some not. And then drugs like methimazole or other painkillers could be available at the site, and it helps quite effectively.
Thank you Thank you very much for the presentation. I was wondering if you could touch upon evidence regarding ketamine-assisted psychotherapy, or your thoughts, how it's going.
We have quite a number of data collected at Sion. I didn't show them, but we see that even though we have different ways how to approach patients, we have we always want that patients are in a psychotherapy program. So it's an adjunct to psychotherapy, and they have some preparation sessions, a dosing session, and integration sessions. And we have a model with one session, or we have with triple sessions. And actually, it seems that both are quite effective, and that the effect is longer than this 7 days when it's in combination with psychotherapy. And we can see beneficial effects for up to 3 months and even longer in some patients. In Sion, we do not focus only on depression. We also treat other diagnoses like GAD, PTSD, and also tried others as well.
About the field study that you did with the ayahuasca, you said that, thank you, that you could compare the different engagement patterns of the people within the ceremony. How exactly do you measure that, whether someone's more engaged or less engaged?
Well, actually, the big project hasn't happened yet. We were there, in fact, piloting recordings and trying to get the experience from the setting, because it's not very easy to collect data in this environment. And we were collecting the altered state of consciousness scale, mystical experience questionnaire, and so on, just to be able to correlate the effects of ayahuasca with the brain activity. But the large project is meant that we would like to compare the long-term effects on mood and well-being and nature-relatedness and other parameters. But this is still to be happened in the future. But let's say at this time we are able to collect hyperscanning data in the Amazon, and not only there, and we've solved quite a lot of technical issues, and we are able now to analyze them as well quite effectively. So I'm willing forward to continue and going there back again and just make a larger study, including indigenous people, because this was just our experiences or our personal data, because we were not allowed to collect the data from indigenous people and from other members of the ceremonies.
Thank you for your questions, and thank you, Tomáš Páleníček, for answering and then really interesting talk.
Thank you.